Now I'd like to introduce respiratory physician, Dr. Lewis Holmes.
Thank you. Yep, I'm Lewis. I'm a respiratory and sleep physician in my own rooms, and I work at Macquarie Hospital as well. I got a lot to go through in not that much time. Wasn't sure how much you guys wanted to know. I've got like an overview of what respiratory-related occupational disease is like, and then we talk about sleep, but that could go on for ages. So here we go. Yeah, your lungs are... we're going to do some anatomy and physiology. The pointer, I doubt, is not really going to work. Okay. So your lungs are just these two sacs involved in gas exchange. We get air from the environment. We get oxygen into the blood. We get carbon dioxide out. That's ventilation. How we survive. Use that to supply muscles and things for energy. You'll have a series of tubes that branch out. You end with a sac at the end called the alveolus. The end of the alveolus has this tiny membrane that air goes into the blood, and that's how you oxygenate your blood. It goes away. Asthma is a disease of the airways. The lung diseases from occupational exposure usually get to the very thin lining at the end there and cause trouble. It's very delicate. The lungs lie in the chest. The chest, this is this picture on the top right, has a lining called the pleura. There's lining on the outside of the lungs. There's a little water space, and then there's lining on the inside of the ribs. That lets your lungs slide in and out, right? Relevant for some of these diseases. In the airways, you have these little hairs on the cells called cilia. That's these on the bottom right. You're always making mucus. These cilia beat the mucus constantly upwards, and then you swallow it, you eat it. So when you inhale dust, pollen, whatever, it mostly lands in that and then gets swallowed later, but not always. Silica and silicosis is a huge problem. Oh, I've got it here, great. This is a disease that's been around forever. Hippocrates described patients with silicosis. Silica is the second most common mineral on the planet. It's in the Earth's crust, maybe not on the planet, in the Earth's crust. Different stones have different proportions of silica in them. Sandstone is pretty high, 50%. Granite is 25 to 50%. When you have like grout, mortar, concrete, that's high silica content. And engineered stone is like 97%. It's all silica, which is why there's this problem in recent times. So yeah, it's everywhere, different proportions in different stones. There's different types of silica. There's silica that's in like a rounded molecule, that's amorphous silica, and then there's crystalline silica, which is more fine, easier to get further into the lungs and cause problems. So it's in all these stones. It's in building materials like anything, bricks, pavers, tiles, some plastics and some manufactured timber. Anytime someone cuts this, it can be inhaled, right? And the way we're doing it now is with tools that are got diamond tips and spin it like 1,000,000 times an hour, and it can cut very finely and distribute this dust like everywhere. And it becomes respirable, that is that you can breathe it in, and it is so small that it gets all the way past the defences. The hair, it's too small for the hairs to beat back upwards, and then it gets stuck, and there's no way to get it back out. This bloke is, I mean, I don't know if this is a demo picture or real, but yeah, he's inhaling a lot of silica, not good. People that cut it, drill it, get exposed to it, but just handling it in a non-ventilated environment, which happens, unfortunately, commonly. And there's been a couple of like outbreaks of acute silicosis in industries where there's been tons of like silica dust exposure. To make denim jeans, they used to like blast the jeans with sand, with like, you know, poor immigrants in an underground factory, and they just have no ventilation. They'd be blasting the jeans, and then they just get acute silicosis, right? You can't see it when it's this small. So human hair is this picture. It's 70 micrometers in diameter. Beach is sand is 90 micrometers in diameter. Silica dust or fine respirable silica crystals are less than 10 micrometers in diameter. If someone's been cutting something, like some brickie came here cutting bricks 2 hours ago, he could still be here, you wouldn't be able to see it, right? We're not designed to interpret threats that are invisible. Workers on the site are certainly not going to think that there's anything going wrong when they just walk through and there's invisible dust everywhere. Because it's so small, it doesn't sink to the ground quickly. It takes a number of hours. So it can float around for ages, which is part of the problem. Similar to all occupational lung diseases where you're working with stone or coal or asbestos or metals, whatever, if it's small and you inhale it, it causes this reaction in the lungs that causes problems. And these problems can be acute or they can be chronic, and it depends on how much you inhaled and how quickly you inhaled it. So silica, classically, you get this chronic silicosis picture where you've got a bloke that's been cutting stones his whole life, well, his whole career, and then 10 years after he retires, he can't breathe. That's like chronic silicosis. And we've got pictures of it later. But you get fibrosis of the lungs because it's filled with silica. You can also get acute forms where they inhale so much silica that they overcome the body's ability to clear it, and the lungs get filled with fluid, and then they suffocate and drown. And there's actually been a few cases of that with the engineered stone cutting, because it's 97% silica and you've just pushed it in the air. And that can come on weeks to months after exposure. And there's nothing you can do about it. Increases the risk of airways diseases, bronchitis, COPD and emphysema. Doubles the risk of getting lung cancer. Interestingly, it can cause autoimmune diseases, scleroderma, lupus and rheumatoid arthritis. Your body is trying to attack this crystal in your lungs, and it can't, and then it develops autoimmunity trying to find an antigen, trying to find something to kill, and then it actually kills something in your body, and then you get an autoimmune disease. Right? Causes kidney disease because your body's just inflamed and doesn't clear toxins properly. So the chronic silicosis, the patient has progressive breathlessness, they have a cough, probably not productive of much phlegm. They feel generally tired and fatigued because they're breathless. They eventually get progressive failure of the lungs, needing them to need oxygen, and eventually they can die of this. Hopefully it stops, but once you've had the exposure and the body's mounting an inflammatory response, it sometimes just maintains itself. These patients, because their lungs are damaged and don't operate properly, they are at risk of getting infections and other complications as well. Yeah, so on the left picture is a normal chest x-ray. The lungs are black. Heart's in the middle. Lungs are on the other side. Air is black, so the outside of the patient is completely black. The lungs are these two greyish spaces. On the right picture, the upper lobe of the lungs has all these white dots in it. And on the stage left, which is the patient's left upper lobe, it's more condensed, right? If you looked at it on the CT, what it is there's these little spots everywhere, and then they coalesce to form these massive spots or chunks, and then that's like useless lung. It's all scar tissue. The patient can't breathe, right? The lung is not engaged in ventilation. Yep. This is what is supposed to happen. So ideal sort of management is you don't breathe any of the silica. Like the proportion of silica you're allowed in the air is tiny, negligible. So they're meant to cut it with tools that are wet with like a high pressure hose, because the drill's going fast, it pushes air out. If you just use a normal garden hose, it's just going to blow the water out and you get silica anyway. And then you need it to be taken away through a vent somewhere else so that no one can breathe it in. Ideally, it's with machinery with no people there, or and the person that's driving the machine is in a positive airway pressure cabin so that he can't get in. And then they wear a mask too. But the mask's got to fit properly. A lot of tradies have beards. I doubt the masks fit properly. So I just think there's a high risk of exposure, which is a huge problem. We do screen for patients in high risk. So patients who are minors, for example, they get chest X-rays every year. They get lung function every year. But that's, to check if they got it and then stop working, stop the exposure. As I said, treatment, you can't really do much. You give them pulmonary rehabilitation, which is if you exercise and make your muscles stronger and your heart better, you feel less breathless, but the lungs are still the same. You cannot train the lungs. You make sure they're vaccinated so they don't get a cold, because that could make them quite sick. You give them oxygen and symptom management. You can give them puffers if they have COPD, but that's about it. There is an experimental treatment called whole lung lavage, where it's an operation. They're unconscious. You block one lung. You breathe through. So this is very complicated. You block one lung, right? You breathe through one lung. The other one you just wash out with water to try to get the silica out. Doesn't work. Last resort, really. And lung transplant as the last problem, the last treatment. Asbestos is... any questions about silica? Because I don't know how much time we're going to have questions at the end. No? It's a lot. Apologies. Asbestos is more of a historical problem. So this is a fantastic compound. High heat resistance, low heat conductance, chemically inert, good for pipes to keep it corrosion resistance, good for Navy ships, right? Good to keep your house strong and the temperature warm. They're flexible, durable, but yeah, they're toxic. There's a couple types. You might not read about this. I read about this. It doesn't really matter. There's 6 types of asbestos, right? The most common is this chrysolite one. It looks quite pretty though, doesn't it? You'd see it's in this stuff, like this Super 6 fencing on the right is still around and everywhere. If it's not broken, it doesn't matter. It was in tiles, it's still in pipes, not new pipes, old pipes. And it's not a problem if it's just there, but when it gets old and degraded, it's a problem, right? So the picture on the left, yes, is like an old degraded piece of fibro sheet. So time has passed now, and it's got little bits of fibre everywhere, and you knock it, it gets fibre underwear, you breathe that in, it's stuck at the bottom of your lungs, can't do anything about it. They used to use like sprays of the asbestos, like in the roof ceiling to insulate it. That's friable asbestos, that's a high exposure risk. Historically, miners, people that built it, people that use it, Navy, I have a lot of, the patients I've seen are all from the Navy, right? They're in the ships. All the pipes are made of asbestos because it's waterproof and all that. And they just drilled into it, cut into it. In brake pads as well, because it's heat resistant. Those are the main things. It's like, there's household contacts too, so that the man would come home, his wife washes his clothes, and then she gets asbestosis from all the dust exposure. Currently, it's people that remove asbestos inappropriately, DIY people, firefighters who should be wearing a mask, to be fair, but because they're breaking down houses that had asbestos in them. And you get old patients who had been exposed years ago from the first industries. This is why I told you about the pleura. So you can get, asbestos goes all the way to the end, and it just lands there, and your body just has an inflammatory response, and you get these things called asbestos pleural plaques, which I know you guys know what that is. So you can see them on the X-ray. They're little, like, well, you might be able to. These little shadows throughout the chest X-ray, and on that right CT, that white bit in the top right corner of that is a calcified plaque. These sit between the lining of so there's the lining of the lung, there's a space, and then there's the lining under the ribs. They sit in there. They don't cause an impairment, but it can be painful. You're trying to breathe, and it's just rubbing against this calcified thing. It's more of a marker of asbestos exposure. You can, however, get patients that have the lining of the lung is full of just inflammation, asbestos, and it's rigid, and then they can't breathe in because the lung doesn't slide. Then they're breathless from that. That's a restrictive lung problem. You can get effusion. So effusion is fluid in the chest cavity. That can be benign, like just the reaction from having the asbestos exposure. It can also be related to lung cancer or mesothelioma. This is a picture of mesothelioma. So cancer of the lining of the lung, usually caused by asbestos exposure. You get it 20 to 25 years after the exposure. Even now, so it's first there's no cure, and then we had chemotherapy, and then there's chemotherapy immunotherapy, which even now it's 18 months with treatment. So yeah, not great. This is the rate of mesothelia diagnosis over time. It looks like we've passed the peak, which is great. That was in 2022. New diagnosis of mesothelioma, because these are older workers who had the exposure, mostly men. So this is, as I say, it's a historical disease, mostly. But there's still patients. I did make a GIF of this CT, but I doubt it's going to work. Right. Asbestosis is just lung scarring, same thing. So when whatever substance you inhale, silica, asbestos, gets all the way down into the little thin membrane, it scars, and then your oxygen can't get into the blood, and then you become short of breath. Can't do anything to reverse it. We do have medications now that stop it from getting worse as fast. Doesn't reverse it. These are bad things that you may inhale in your occupation that can cause lung disease. That was pretty quick, 16 minutes. So we're up to sleep disordered breathing. Great. So yeah, I think sleep is a tricky one with this medico-legal claiming. I'll start with the things that are certainly objective and easy. So sleep apnea is a common condition. This picture this is what I tell my patients. So humans are evolved to have a flat face, big tongue, so we can socialize, communicate, right? The cost of that is that the back of our throats is actually very narrow compared to, I guess, other apes. So behind your tongue and your uvula is narrow. There's muscles there called the pharyngeal dilators that are awake when you're awake. Stupidly, when you sleep, they sleep. So then your tongue falls backwards and the airway gets blocked. People feel this as a choking, gasping sensation. Snoring is a noise that it makes as the airway narrows. And then the oxygen will go down, the carbon dioxide will go up, the patient will wake up. And they may wake up gasping, choking. They may not even realize they've woken up. Like people with sleep apnea wake up 15, 30 times an hour. They don't wake up for real 15, 30 times an hour. But objectively, on the sleep study, they do. It's most commonly obstructive, so I just described obstructive sleep apnea, but you can get central apnea. If your brain doesn't sense the carbon dioxide properly, you just stop breathing transiently. Eventually, hopefully, you restart breathing. High prevalence of sleep apnea in the population. 9% of all Australians, 20% of middle-aged men. Under-recognised in women. Women, I don't know, this is both among the community and doctors. It's thought to be insomnia or anxiety is the main thing, but actually a lot of them have sleep apnea. And I would venture a lot more people should have sleep studies than do. So we have the anatomical predisposition. That's a non-modifiable factor across everyone, but there are aggravating factors that make it worse. So there are certain drugs. Obesity makes it worse. Position can make it worse. What does it do to you? Well, it makes you sleepy. It can cause anxiety and depression, inattention, poor concentration. They wake up with headaches and dry mouth, and they wake up throughout the night. There's insomnia. I think anyone that has insomnia, you need to make sure they don't have sleep apnea, because they could just be waking up because of these apneic episodes and they can't get back to sleep. I see it all the time. Sleep doctor in Adelaide coined COMISA, combined obstructive sleep apnea and insomnia, for this phenomenon. There's a high rate of workplace errors, motor vehicle accidents. They can't drive a heavy vehicle if they're not treated. It's not like, I don't know, some of these IMEs, they ask how many hours you think they can work. Hard to say. They could probably work a full day, but not well. There's a lot of presenteeism and just low output, low productivity. And there's more sick leave amongst people who have sleep apnea than don't. How is sleep apnea caused by workplace injury? Hard to sort of say. I think definitely if they've put on significant weight since the injury, right, because they're sore, they're not exercising, they're eating poorly because they're probably a bit depressed and they're not doing anything, that can precipitate OSA, sleep apnea. There are medications that are used for analgesia, like the opioids and others, that can cause respiratory depression and make sleep apnea worse. Insomnia can come with pain, can come with anxiety and depression, can come with sleep apnea. Very difficult to define, and in the guides, it's like it doesn't say anything about insomnia, so there's no like evidence or guidance. Sleep position. So usually, like 50% of people with sleep apnea, it's worse on their back than on their side because of gravity and the tongue. I've got some evidence and comments about that in a bit. All right, I think, so in terms of these assessments, I reckon you could kind of consider obesity as a surrogate for sleep apnea. So patients put on weight has become obese after an injury or after an event and says they have sleep apnea that's newly diagnosed and says they didn't have symptoms before. I don't know, I guess they've gotten sleep apnea since they've put on weight since the injury, right? That's kind of my only hard evidence of in terms of medico-legal claims. Obesity should probably be its own, I don't know, I think the society thinks of obesity wrong. It's a chronic condition, right, in my mind, causing a lot of health issues, and it's multifactorial, driven by a lot of things. Pain, depression, physical inactivity, you put on weight, you eat more food because you're tired, because you've got sleep apnea, you make poor food decisions, you don't exercise, and then you get in this vicious cycle. Yep. There's the drugs I mentioned. Alcohol makes it worse. You'll all snore tonight. Muscle relaxants make it work as well. And there's benzos and non-benzodiazepine sedatives. They all make sleep apnea worse. And actually, the problem with insomnia is that they see the GP and get given like a benzo, and then actually they've got sleep apnea, and now they're worse, and now they're more tired, which I see clinically quite a bit. The sleep position stuff, like I've seen this in a couple of reports, and I disagree. You can't tell what position you're in when you're asleep. I think it's nonsense to say otherwise, and I've got evidence to say that. So yeah, as I said, 50% of people with OSA, it's worse on their backs, right? And positional therapy is there in the literature as a treatment option for sleep apnea. So if you tell patients to lie on their side, then oh yeah, they don't really have as bad sleep apnea. I've never had success treating a patient with that. Like there's no device that you can get that makes them stay on their side reliably. There is this thing from ResMed that is like it's like a dog collar, and it vibrates when you lie on your side, but then they wake up, it's kind of makes them tired anyway. I think that's nonsense. But no one wants to use CPAP, so they try it. Patient-reported supine sleep. So there's two studies. One of them has you have a group of patients, they do a sleep study, you record what positions they were in. The next morning, you ask them, what position did you think you were in? And then one of them asks them, what position did you think you were in when you fell asleep? And so the one that said, what position did you think you were in when you fell asleep? Only 30% of patients were correct. It's like you don't even remember what position you were in when you started sleep. How are you supposed to remember what position you sleep in? And then they've given, so there's this value called the negative predictive value. So the chance that, if a patient tells me that they do not sleep on their back, so they never sleep on their back. So they've said, before my injury, I never slept on my back. Now I've had an injury, I always sleep on my back, and now I snore, right? There's a 24% chance that they never sleep on their back, or that they never did sleep on their back. Nonsense. This is a graph on the right. Yep. So this is the y-axis is proportion of time that patients spend on their back, so supine sleep, objectively measured on a sleep study. And then the patients are asked, how long did you spend on your back? And then, so they've said none, some, half the time, most of the time, all the time. I don't know if you guys can read these graphs, but like the No? Okay, great. So this is a forest plot, but the longer the bar, okay, so the big blocks is like where most of the data lies, right? So people that said they had no sleep on their back, up to 37% of them slept on their back, right? People that said that they spent all night on their back, actually most of them were right, but then there were some people, so these outliers, that line going down, only spent 47% of their time on their back. It's just unreliable, is what I'm trying to say. How do you treat sleep apnea? The first line best treatment is with CPAP therapy. This is a machine with a tube with an airtight mask that blows air into the airway and pressurizes and splints the airway open. Patient stays asleep. People, like, it's fine. People have this thing about it being a scary treatment. It's really not that hard. The problem is that you go to, I mean, this might be cynical, but you go to ResMed now, you get a crap sleep study, they sell you a machine, they don't really follow up with you, you get set on the wrong pressure. If it's on the wrong pressure, you can't use it. Like too high, uncomfortable, too low, doesn't work. Yeah. But CPAP's the way to go. Weight loss would be the second line treatment. Again, weight loss. So there's these new medications, the GLP-1, GIP agonists, Mounjaro, Ozempic. These are great. They treat obesity as a chronic condition. Interestingly, I'll tell you, this is a bit of a side note. So the studies where they do, so the study for Mounjaro versus placebo, right? So they had a group of patients with sleep apnea, who were obese, and they said, okay, well, half of you we're going to give this drug to lose weight, and you're going to get a dietitian, and you're going to get a caloric restricted diet, and you're going to get an exercise physiologist to give you a program, and you're going to get the drug. And then there's blast with the drug. They get the highest dose of the drug. And then the other group, they get the dietitian. They get a 500 kilocalorie reduced diet per day. They get an exercise physiologist to tell them what to do and how to exercise. And they don't get the drug. They get a placebo. After a year, the drug group loses 30% of their weight. The non-drug group loses 2% of their weight. Does that not mean that diet and exercise does not work? I think it does. The other option, I think, last line, is a mandibular advancement splint or a mouth guard. This is a top and bottom mouth guard that pushes the bottom jaw forward to make room at the back to open the airway. The only evidence I've seen for this is from the companies that make this, so it's inherently biased, but it does have efficacy in mild to moderate sleep apnea. Not in, like, so it wouldn't work in obese people with sleep apnea or severe patients with sleep apnea. I use it as a reserve, so they don't tolerate CPAP for whatever reason. And some people don't, like they just can't use it. You can try the splint. MMI, I would say if someone's tried CPAP or can't afford CPAP, tried a splint or can't afford a splint, I don't know, it's a bit controversial to say they need to have had Mounjaro or weight loss. You can say, oh yeah, I've tried to lose weight, but I don't know how reliable that is. Like, you can't prove it. Insomnia, as I said, like, no mention at all in the guidelines or the AMA5 guidelines or the CIRA guidelines whatsoever, which makes it difficult. I think there's been a couple of cases where your insomnia should be incorporated into the rating of the pain or the psychiatric illness, which I don't know if the pain physicians or the psychiatrists think about sleep as a condition, or insomnia as a condition, which means it probably goes unrecognised and unaccounted for, right? When I do in the guidelines, it says, a patient's ADLs, and you can say, oh, well, their ADLs are affected, and one of the ADLs they say is a restful night's sleep. So if someone has insomnia, they don't have a restful night's sleep, so their ADLs are affected. You've probably seen some reports that have said that statement. So that's how you incorporate insomnia, I guess, and you can increase the rating that way. But yeah, otherwise it's unaddressed and probably needs to be looked at because it's common and it's a multifactorial issue that is difficult to rate, I suppose. And the sleep study, so the way we measure sleep is with a polysomnogram, ideally in a sleep lab. Nobody sleeps well on a polysomnogram in a sleep lab. They always wake up for no reason. You can't tell if that's pain. You can't tell if it's because they're in a sleep lab and they're anxious because they've got all this crap on them. It's a lot of stuff. Yeah. You can tell if they've got sleep apnea, though. Cool. Questions? Yes?
So workers' comp space, and a trend we're noticing is that claims are being put on for both sleep apnea and insomnia. And one of the hurdles that, well, not hurdles, but one of the commonalities we're seeing is that insomnia is now being described as a neurological condition that is now removed from the initial pain source, and therefore it's attracting high impairments, 10% and above. And we're not finding any competing opinions, and it's not coming from neuros, they're coming from respiratory physicians. So do you have any comment on that you can share?
Yeah, I had a case with that statement last week. I disagree. Yeah, for those reasons, you can't it's yeah. Oh, so sorry. There are some reports or some people that say that once insomnia is so insomnia is a chronic condition. It's multifactorial, as I've said, and there's some people who have written that, like, you know, it's become, the more you have it, the worse it entrenches itself, and then they get worse anxiety, and then they get worse insomnia, and then it becomes a condition of itself, and then it becomes a neurological condition. Right. So that actual statement that you've said, like in the guides, the definition of a neurological condition is like a head injury, right? The way you read it. So that is not what, like, it's not viable. Not viable. Not, you can't. That's not true. What that statement is, right? That's all I can say. I mean, it's not. It's a neurological condition in the same way that depression and anxiety is a neurological condition. It's not a neurological condition like you've got a brain tumor or something, which I think is clearly defined in the guidelines, and that's the intention. And I think that is a circumvention of the guidelines for some motivation. Yeah. Any other questions?
So if sleep studies are subjective in terms of if you're in a clinic and doing a sleep study that it's not the most accurate, they're objective. Okay. So is there any other way that you can diagnose a sleep disorder other than just doing the sleep study?
Oh no, so sleep studies are, so it is objective. Sorry. So sleep studies are objective data. They measure your brain during sleep, whether you're asleep or you're awake, what your breathing's doing. And so it's measuring, and what we measure, okay. So you measure your brain activity, you measure your eye activity to help you stage the different stages of sleep. Your watch and phone try to stage sleep. That's nonsense. You see what we need to do. You need leads on your eyes, leads on your chin to measure your muscle tone. We measure the flow of air in the mouth and nose to see if air is going in and out, because if there's no air, then that's apnea. We measure the chest and abdominal movement to see if the person's breathing. We measure the legs to see if they're kicking around during their sleep. So it is an objective measurement. I'm saying that the people who have a sleep study are more likely to, well, you're more likely to sleep on your back because of the equipment. So you're biased to supine sleep. You are more likely to have spontaneous arousal. So the brain wakes up for no reason. Because you're in a sleep lab, there's 10 other people around, there's nurses walking around, it's cold, the bed sucks, that sort of thing. And just to say that the sleep study is evidence that they have insomnia is not a diagnosis based on a sleep study. So that's all I meant. It is an objective test. The way we rate, the rating of sleepiness is a subjective test though. The Epworth Sleepiness Scale, you've probably seen that. I mean, it is a validated questionnaire for sleepiness. I don't really find it that useful in like clinical practice, because patients will be like tired as anything and they score low, right? And patients are not tired and they score high, and it's just not, I don't know, I see this discordance. Objective testing would be, there's a study called a maintenance of wakefulness test, or an MSLT, but you do a sleep study and then there's two versions. So maintenance of wakefulness test is this is what we do. A truck driver says they've got sleep apnea, they want to drive the truck. They say, I'm not using CPAP, I'm not tired. Right, you do a maintenance of wakefulness test, you do a sleep study, and then the next day you go, right, here's a dark room, you sit in this chair and you stay awake for 40 minutes. And they do it 4 times. If they can stay awake for 30 minutes on average, then they must not be sleepy, pathologically sleepy. The converse is that is an MSLT, which is you do a sleep study the next morning. So the patient says they're really tired. You want to measure how tired they are. There are conditions like narcolepsy where they're super tired. Like another thing with that, I'll get to that. So there's conditions with narcolepsy where they're super tired. To measure that, you need to do an MSLT, which they do a sleep study, and they don't have any sleep apnea on that study. And the next morning you do, there's 4 periods, you say, turn the lights off, close your eyes, have a nap, and we see how quickly they fall asleep. 4 times. And narcoleptic people will fall asleep in like 2 minutes on average, like every time. They just fall asleep at the drop of a hat. Yeah. And so with that, this sleep apnea and insomnia, and they get a combined impairment, that impairment can be up to like 20%. The guidelines have an example of someone with narcolepsy, and it's like 39% for someone who has narcolepsy, and someone with idiopathic hypersomnia, which is another like brain disorder. And this guy, they describe this patient as like falling asleep at the wheel, doesn't remember, has a sleep attack. They're like 19%. So you can't have someone with sleep apnea who has a higher impairment than someone with idiopathic hypersomnia. Like they're just not that tired. Yep.
Would you use an ENT to help with the diagnosis of OSA?
You have to. Like the guides say that you need to have an ENT assessment to say that they've had maximum medical improvement. I don't really, clinically I don't think it's necessary, but yeah. Because snoring is not, everyone thinks snoring is the nose, it's not the nose. It's the back of the throat.
For recording insomnia, what about tech like 8Sleep or like watches? Can that be used as like a diagnostic tool?
So we do use a thing called actigraphy, which is it is a smartwatch, right? But it's a clinically validated smartwatch that is comparable to a lab study that accurately detects when someone's awake or asleep, right? No one does this because there's no Medicare rebate for it, but it is very useful for patients with insomnia. So you can put it on and you can say that, you know, you slept for 6 hours, you woke up 4 times, this is how long it took you to fall asleep, this is how long you've stayed asleep for. And it's very useful for patients with insomnia because they often don't think they fell asleep. Like they'll say, oh, I know, they didn't sleep all night, but you would be dead, you have to have slept all night. So you can see how much they slept. And Apple Watch, they're all right, they're like 70% reliable, but it's not for clinical use, yeah. Okay, thank you.